Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello, everyone, and welcome back.
Welcome back. You don't sound like Ash, nor do you look like Ash. Welcome back, Marissa.
Thanks for having me.
Thank you so much for coming in again. We've got another great topic to talk about. Unfortunately, Ash couldn't make it. We're kind of telling the story a bit before, but she's broken her arm, everyone, and it was two teenage boys on an e-scooter that came around a corner and knocked her out. So I just like to say, be much safer on e-scooters, please, you young men, because she now has to get that sorted. Oh, how horrible is that?
Poor Ash. So thinking of you, Ash, we miss you.
We do miss you, and I know she'll be listening to this because she'll be super keen because we have a very special guest with us today.
Yes, very
She's
exciting.
Been really hopeful to be able to speak to. So today we have the wonderful Dr. Colleen Peyton from Northwestern University. Thank you so much for joining us on this podcast, Colleen. Welcome.
Yes, thank you for having me. I've been a big fan of the podcast, so happy to be here.
It's so good. We're so excited to speak with you because we'll really be talking to you about a piece of work that you'll be presenting again at the American Academy in October, New Orleans. And in fact, for everyone, her article is actually up for the highest honor, the Gayle G Arnold Award, which is chosen and highlighted by the scientific committee because of its high quality. And so, this is data that's just been produced, and it's going to be really exciting to have the opportunity to speak with you about that. So congratulations on that, Colleen. It's a huge honor.
Oh, thank you so much.
Your work is absolutely amazing, and when I was reading your bio, I was in awe. So I'm going to tell everyone a bit more about you before we jump into your article. So Dr. Colleen Peyton joins us today. She's an associate professor in the departments of physical therapy and human movement sciences and pediatrics at Northwestern University Feinberg School of Medicine in Chicago. With over 15 years of clinical experience as a pediatric physical therapist, specialising in high-risk infants, she earned her doctorate from the MGH Institute of Health Professions. A pioneer in early neurodevelopmental detection, Dr. Peyton became the first licensed tutor of the Proctor General Movement Trust in North America, training clinicians worldwide in the general movement assessment to identify cerebral palsy as early as infancy. Her research integrates motor behaviour analysis with advanced brain imaging to track developmental trajectories, driving better outcomes for vulnerable newborns.
Wow, everything about that is incredible. I love that. We have so much to learn from you today.
This work is incredible, and we're very, very excited to jump into this. But it wouldn't be a podcast without a question, an icebreaker, in fact. So, Colleen, look, you've worked and lived across America and Australia, and worked with people in both areas, both countries, continents. Uh-huh. So, what is the biggest similarity and difference between Americans and Australians?
Good question. Well, I have to admit that I've never yet been to Australia, so I can't speak from what's going on there.
Yep.
But I will be coming this year, so I'm very excited.
Exciting.
But I would say there's probably more similarities than differences. I mean, I think at least in the people that I've met and work with, we have so many similarities in that we really care about outcomes for children.
Yeah.
Everybody's that I've worked with in this space, Australia, US, wherever, people are really, interested in research and getting the best evidence to support these families and children. So that's very similar. I think that there's some differences that I've noticed when the colleagues from Australia come over. First of all, the way that we say physical therapist, and you all say physio.
Yes.
That's a great one.
That's a really good one.
Yeah. Yes. And then I think also my Australian friends are very particular about their coffee, where I think we just drink these big heaping glasses of watery coffee. Yes.
Yeah, the drip coffee. I remember being startled at that and saying, how do I get a flat white?
Yeah.
Well, yeah.
Exactly.
The flat whites have made it across now, though, hasn't it? You guys have flat whites now?
Oh, yes.
Yes.
We do, but I think it's not the standard. So normally we're always on the hunt for a good coffee when we're with the Australian colleagues. Yes.
Yes. That is so interesting. I love that you picked that up. And yeah, physical therapist, physiotherapist.
That's a great one
yeah,
as well.
That's a really big one.
Yep.
Yeah, I like those ones. Marissa? You next.
Look, mine would be, because my husband is NFL obsessed because he lived in America once. So I have watched a lot, and so I would say the similarity is mutual love for the game.
Yeah.
And, that preparation for a Super Bowl, and we've got the AFL Grand Final in Australia, and there's big build-ups and big parties and lots of yummy food. So that's a similarity. But the difference I would have to say is the amount of people on the sidelines in an American football game warps my mind. There is probably absolutely huge, because there's obviously different teams. They've got so many players, so many coaching staff, the cheerleaders. It is just such a big, spectacle, but such a big sport. Quite amazing, but just a bit different to AFL here.
Yeah, I love that you've done that. You talked about NFL. That's great. Well, I would say the biggest, from a similarity perspective, I think we all love the great outdoors. I feel like with Australia, we're such a big continent. We have mountains over on the East Coast. We've got some desert as well, and we love being by the beach. We love doing things outdoors. And I feel like, I don't know, every movie I watch, Americans seem to love their outdoors. You have beautiful parks and beautiful things that are out that draw people out. I love that. Differences, I'm going to talk about food, because the last time I went to the US, I remember ordering something thinking, this could be okay. But it was the most biggest serve I'd ever had in my life. It was like pancakes.
Pancakes.
I couldn't, I think I had maybe a tiny little wedge. It was like an eighth of it, and I felt really bad, but it was stacked really high and it was massive. And I thought, I don't know if that's something I could finish, but I just had no idea. I was so shocked. Felt like a family meal for me.
It is. The serves are wonderfully big.
Yeah.
Quick question. Because obviously Vegemite here is massive. Do you have Marmite there, or is there some sort of vitamin B dark black spread that you use that's similar to Vegemite?
No, not that speaking on behalf of all Americans, I might be wrong. However, not that I'm aware of. That's not a standard breakfast item or food item that I think is common here.
Okay.
Yeah.
Because you've heard of it though. It's obviously very big in Australia. Vegemite on toast is an absolute favourite for me. Maybe not for everyone in this room.
I've been gifted some as well.
You have?
But I have to say I've looked at it in the cabinet, but I have to say I've yet to try it. I'll be honest, but I should now. You're inspiring me to try it again.
You're going to need a thick layer of butter and then just a light layer of Vegemite, and you're good.
Just a bit of Vegemite. I think it looks like chocolate, and you spread too much on it, and it's terrible. So lots of butter. Marissa's absolutely right. White fluffy bread, no nutritional value whatsoever, and then just this tiny spread of Vegemite.
Now I want some.
A little bit goes a long way. It
does.
Like.
Yeah. And trust me on that one. I think the first time I had it,
we could be talking about this similarity next time, about how the mutual love of Vegemite. Stay tuned.
One day, Colleen, you let us know.
All right, that was some
That was a
great
good one.
differences and similarities there. But now we will bring everyone back to this amazing topic we're going to talk to Colleen about today. So, Colleen, can you start by giving us a brief overview of what the General Movement Assessment is and why it's such a valuable tool for predicting cerebral palsy in infants?
Yes, sure, of course. So this tool can be used in infancy, and it's based on this idea that the fetus and the young infant are moving spontaneously. So even from the time that they're only the size of a kidney bean, a small bean, at 10 weeks post-menstrual age, they have these complex rotational whole body movements, even though their body is quite small. And that actually is pretty consistent throughout pregnancy and into the first 4 or so weeks of life. They move almost in the same manner. And if they're born preterm or early, they still move in a very similar way, whether or not they're in the womb or they're in the isolate in a neonatal intensive care unit. And really what is generating these movements are the brain. And then we go from having these sort of rotational movements that are sort of elegant and smooth to about 5, 6, 7, 8, 9 weeks. We transition from these sort of smoother, I want to say, someone just recently said in one of the courses, like a cat slinking along, to something that's So something that's more, I guess, staccato in nature, where it's sort of individuated and multiplanar. I'm doing this on the camera, so trying to explain for the listener who can't see, these tiny movements that go in all directions that are more individuated, and those are called fidgety movements.
Right.
And those start to show up around 6 to 8 weeks of age. And then they go, and that's what we're investigating in our paper. How long do they go? And basically the idea is that we can categorize these movements based on the age. And when there's then an injury to the brain, the babies still are moving, but they're moving slightly differently. So what is producing these movements is the brain and the nervous system itself. So the way that they're expressed can tell us a lot about the nervous system. And because cerebral palsy has a lot to do with movements, if the movements look differently, then we have some indication that they might have a higher probability of having cerebral palsy.
That was a great explanation. Thank you so much, Colleen.
And it is just so amazing. I remember when I first heard about this coming out, and just how it's influenced the whole trajectory in terms of early diagnosis is amazing. And that you can pick up something by being able to assess movements at such a young age is incredible.
Yeah.
So you told us a bit about the absence of fidgety movements being a predictor of CP. Can you tell us a bit about the age range? Was it between about 10 and 16 weeks, or just what that might look like?
Yeah, so actually that's sort of a little bit about the question that we were asking in this paper, because what we've known from like a lot of my colleagues that have come before me that amazingly we're able to find, because the babies are producing so much behavior on their own. And I should say also this is spontaneous behavior. So no one's touching the baby or doing anything to the baby to get them to move. They just move spontaneously. And the way that they move these tiny fidgety movements, babies that have fidgety movements are a lot less likely to have cerebral palsy. So these movements we can see in most babies. What I was taught originally was between 9 and 15 weeks.
Right.
But as a clinician and a researcher, when I was first starting, I was looking for these movements and found that sometimes that timeline would vary. So that's sort of, we looked in our study between 10 and 20 weeks, and we looked every 2 weeks to see about the trajectory of the timeline of fidgety movements. But normally we would have previously said 9 to 15 weeks was sort of the age when we expected most babies to have those. But that was sort of established quite a while back when they were doing the original studies and maybe didn't have quite as many videos of the babies over time.
That is so interesting, isn't it? Because, I can see where this is going from what you're trying to do here as well. Because if you do have that age range, there's always going to be variance within that. And if we're realizing now that general movements is such an important piece of an early diagnosis, you don't want to miss out on picking up what might be happening if they're slightly out of those age ranges, particularly if that's part of your protocol, I imagine.
Exactly. Yeah, it's quite a narrow window. So we really want to make sure we have the right window so that we're correctly identifying the presence or absence of these fidgety movements.
Yeah,
exactly.
Absolutely, especially for what it means for a family at that still, the child is so young, but having that diagnosis or even that risk of at that age is so, I guess, instrumental. But we'll go into this more as we go into your paper. I want to chat now, just before we go into it more, about your paper included infants with both with and without medical complexity. And can you explain to us about what medical complexity encompasses in this context?
Sure. So we wanted to look at babies that we would follow in a follow-up clinic that graduated from a NICU that we would be assessing anyways. So we included babies in sort of the kind of traditional group that were born early with a younger gestational age, a younger birth weight. We also wanted to look at babies with congenital anomalies that require surgery, because a lot of times they're excluded from studies.
Yes.
But we still are curious about their development, and we still realize that they've had a lot of time in the hospital with different medications and surgeries, and we want to understand about their trajectories as well. We also included twins. So there was some interest about twins and how did they develop? Was that any different from a singleton birth? We looked also at babies who were born at full term but had some sort of neonatal encephalopathy that required which is like an early form of signs that the baby is not had enough oxygen during the birth process. So those babies receive something called therapeutic hypothermia, and we wanted to look at those babies too. So that is another big group that we're following in neonatal follow-up clinics. So those were the babies that we included in the study. And then we included babies who were born full term with no history of any sort of medical complexity, to see how are those kids different or the same as the other babies that we follow in clinic.
That is so great because it's very pragmatic, isn't it? It's you've thought about what real practice looks like because that's often where, it's very heterogeneous and what does that actually look like when you're in that setting? What might you expect? I love study designs that are like that. Colleen, can you talk us through a little bit more about how the study was actually done? Because this was an international collaboration across many sites. Do you mind just going through what that actually entailed?
Yes. So actually, and this study also occurred during COVID, which so we had a perfect.
Oh, gosh. Okay.
I know. But we had the perfect study for COVID because what we did was we used Alicia Spittle, who I know has been on your program before from Melbourne.
Alicia. Yes.
Yes, me too. She developed this app at University of Melbourne called Baby Moves, in which the parents can film their babies at home. And then they upload it into a server that we all have at research institutions called REDCap. And so we all have the same research program across our universities in Italy, 2 locations in Australia, 1 in Melbourne, 1 in Sydney, and then 1 in Chicago. And we programmed this app to ask the parents and notify them based on their baby's date of birth and expected date of delivery, when to film their baby. So they would get a notification. And then Alicia very smartly and her colleagues designed this tool so that parents could know where to place the camera away from the child. And they have a little baby outline so that you can make sure your baby's within that in a set of instructions. And so it was all done by the families that sent us their video data in a standardized way that we could use across sites. And it was perfect for COVID because we had already planned that study design before COVID. So we could continue to collect data since we never anticipated an in-person visit anyway. So we really wanted the parents to help us out.
Gosh, that is so good because there's been so many studies that were disrupted during COVID. I mean, we've spoken to so many researchers now that went, a lot of our interventions were impacted, and the shift to the ability for parents to be involved, or telehealth has really come to the forefront. But this was really thought about right from the beginning. And I guess that was such an advantage to be able to run a multi-site study because you had parents as part of it. Wow. Yeah.
And I think the other thing that is really an advantage of having the families help us is that, when I first started in general movements, I haven't been in it that long, but about 15 years ago, there were no cameras on phones at that time. We were just starting to have smartphones. It's hard to remember a time when we couldn't create so much content from our phones. But I think the original studies were done in the late 90s where they had to bring these big camcorders, and most of the babies had already left the NICU. So they weren't getting as many videos because the babies would have to come into the lab or, these big camera setups. So we had a lot of information about when they were younger in the hospital, but we had less consistent information about these babies over time when they were in this three-month window. So the technology that we have now that most of us have and access to a smartphone with a video camera, and most parents are filming their babies anyway. It really made this kind of study possible and feasible for families because they already are filming and taking lots of photos and content of their newborns anyways.
That's beautiful. And so how was recruitment? So you sort of said that, you recruited quite a range. What was the process of having the families get involved in the study? And what was that like?
So we looked at those specific groups I mentioned, the babies that were born early, the babies that were born at full term but required cooling, babies with congenital anomalies, and twins. And so we we look through sort of hospital databases to recruit those babies.
Yep.
And then some of us also found some babies who were considered the controls that didn't have any of those other conditions that were born full term with singleton births through the hospital or through the community.
Right.
And we just reached out to the parents and said, would you be interested in doing this? And we had a lot of positive responses. So we could do all the data collection remotely, and a lot of families were willing to help us.
Yeah, that's fantastic. And I guess that does reflect on the desire to be able to have that information, to be supported, but also that the process of using the smartphone app wasn't particularly onerous. Like, it was something that they could do with relative ease. Yeah.
With no undue pressure on the child. You know, like you said, it's spontaneous. You're just filming them doing what they're doing.
Yeah, in the best setting you could possibly do it, in the safety of their home. Yeah, absolutely.
Yeah.
Yep.
Yeah.
Now, in terms of rating, you go.
No, go ahead. It's okay.
No, I was going to say, so blinded raters then score the videos, and we're looking at the presence of fidgety movements at each time point. What training or protocols did these assessors have to ensure reliability and consistency in these assessments?
Yeah, so actually the way that this sort of came about was, at the AACPDM meeting that's coming up, it was, we were talking with colleagues about this and, what do you think about this topic? What do you think about this topic? But all of us that were involved, each site had one of us that was a GM's Trust trainer. So we were all, at each site, we were certified to teach other people about how to do the method. And each of us had a lot of experience with GMs. And we met on Zoom to make sure that we were all in alignment. But we had already been sort of practicing this for a long time, each of us. So that made that process a little bit easier. And always looking at the same cases when we teach the course as well. Sure. And then each within our research teams as well, we sort of kept that standard going. Everybody had been trained, at least in the advanced course of the GM's assessment, and passed reliability test. And then we established reliability as a big group also with some cases as well.
That's so great.
So super thorough in terms of their ability to predict it, which is as expected, but is fantastic. That's wonderful.
Can I ask about doing the GM's course? What sort of, just for our listeners to be able to hear from you, what's actually part of becoming a GM's assessor? Like, if they want to start and embark on that journey, what does that look like?
Yeah. So what it basically does is it's about 3 to 3.5 days of watching a lot of different types, lots of different baby videos, so that you can train yourself to recognize the patterns. Right. So, I always like to kind of use this analogy. I'm an adult who has a stroke. We can tell by the way that they move and the way that they behave, like their behavior, just like babies' behavior, is an indicator of their neurologic function. Sure. So there's certain postures and positions and ways that they move that we most people recognize, even if they don't have a medical background, that indicates that maybe they had a brain injury that's a stroke on one side that causes the other side to move in a certain way. Yeah. Most people can recognize that that's the case. Well, it's not so dissimilar in babies where they have a brain injury as well, and then they move differently as well, but they're not walking and talking yet at the time of their brain injury. So we have to be able to recognize that what is the way that a baby moves at different ages when they're younger. And then we can recognize, similar to when we see someone moving a little bit differently that's had a stroke, there's ways that you can recognize different patterns of movement in babies that indicate a brain injury in some cases, or a movement difference that they have as well, that can help us to support that family sooner and get them earlier intervention. So when we do the GM's training course, that's what we're doing. We're teaching clinicians, researchers, and any type of clinician, and even some people that don't have a background with babies, because what we're really doing is getting them to recognize patterns. Right. This is the way babies move in this stage. This is this type of pattern. And by the end of the 3 or 3.5 days, we have a pretty good reliability. Like, people are pretty good at recognizing patterns when they've had enough practice. That's sort of that process.
Wow. Yeah. And then after they've done the course, the expectations you keep practicing, right? Like, you're working in the area to keep your skills up. That's sort of part of the the recommendations from training. Is that correct? I feel like I hear that from some clinicians. Yeah.
Yeah, and I think like we'll have evaluations and we'll say, you know, when will you use the skill? And it's like, we'll use it tomorrow or today if they're going back to work that day, because you don't need anything more than your eyes, really. Wow. I mean, a video camera is nice so you can have a recording, but you know, clinicians are already looking at babies.
Yes.
Every clinician who works with a baby, they're looking at them. So it's just with a new lens and focus. So I think most people that come to the course are working with babies and they can apply it right away, even with their own babies or friends' babies, you know, they're amazingly all producing very similar types of ways that they move. So
that's fabulous.
Yeah, so it can be fabulous. Yeah.
Well, let's get into the results now. We've been obviously leading up to this point. Now, I saw that you had, out of the 484 recruited infants, that is no small number, 438 videos provided for analysis, resulting in over 2,000 videos. I think I've got those numbers right. Can you tell us now, what are the main results? What did you guys find?
Yeah, so I guess the question that we wanted to see is, how do their fidgety movements evolve over time? Like, is that window still the same when we really look at groups that encompass all the different types of babies that we see in follow-up clinic in modern day times?
Yeah.
And we found 4 different trajectories of fidgety movements. And so that was without knowing what conditions the babies had or what groups they were in. The statistician went through and did this sort of complicated trajectory analysis that looked at, are there different patterns that emerge that encompass all these babies? And he found 4 different patterns. Wow. And one was probably the easiest to describe, which is that between 10 and 20 weeks, when we film at 6 time points, the babies had fidgety at each time point. So that was one of the groups. So we can call them the consistent fidgety group.
Right.
The biggest group, the biggest percentage of the sample was sort of what was described originally by the Prechtel group, which was that fidgety movements were consistently present between 10 and 16 weeks, but started to taper off a bit, so that by about 20 weeks, only half of that group had fidgety movements anymore. So that was sort of the original trajectory that was expected.
Right.
And then we had sort of a delayed onset or a later onset fidgety movement, so that between 10 and about 14 weeks, maybe only 60 to 80% of those kids had fidgety movements at those earlier time points. And then the rest of the time, from about 14 to 20 weeks, they had pretty consistently present fidgety. And then the group that was the most different from the others was a group that none of them had fidgety at 10 weeks. And then the prevalence was the lowest overall and increased over time, so that around 14 weeks and onward, about 40% of those babies had fidgety at any given time point. So that group, you know, over half of them, there was a chance that they maybe didn't have fidgety at all, but especially none of them had fidgety in the first 10 to 11 weeks, which is interesting.
Because like you said, that would originally been in your time point when you would do the assessment.
Yeah.
So it was that
exactly
delayed kind of.
Wow. That is so interesting. That would have been so fun to see that old graph out. Once the stats go in, to actually see, it's like, oh, I see something here.
Exactly. Yeah. So these patterns sort of emerged. Exactly. Yeah.
So did you have, so that you've explained, is that all 4 of the groups, or was there one more? Group 4.
Group 4,
with the lower prevalence of fidgety movements.
Yeah.
And I know that was associated
with that
with
last group.
Yeah, with that last group, with conditions like the bronchopulmonary dysplasia or intraventricular hemorrhage, as well as lower gestational age and birth weight. Were there any other surprising associations or non-associations with this group?
No, and I think that would be probably what we would anticipate, that the babies with lower prevalence of fidgety or lower chances of having fidgety at all would be the ones that were maybe born a little bit earlier or with lower birth weight, or they're more likely to have an intraventricular hemorrhage or bronchopulmonary dysplasia. So those kids tended to be the most medically complex, and the kids that we follow closely to begin with. But one thing that was sort of interesting was that those babies that had congenital anomalies, they didn't fall into that group. Like they weren't significantly more likely to be in that group than others, which was, I think, a bit surprising. We thought maybe that they would also be included in that group, but no, they weren't. Yeah.
Right.
Which group did they tend to fall into?
Well, so they were sort of equally distributed among the other three groups. And so were the controls, actually. So that was interesting, too. So the controls were evenly distributed through those first three ones, the ones that weren't low prevalence, meaning some of the controls were in the sort of delayed onset group that didn't really have as much fidgety in those first 2 weeks. So that was a little bit surprising. Like we might have thought that they would have had consistent fidgety throughout, or maybe that they would have tapered off. But that wasn't the case. So that was a bit surprising.
Oh, okay. Colleen, what do you think this all means? What's your interpretation of all of this? That's a surprise.
So basically, so I think that in some ways it's surprising. In some ways it's sort of what we expected. So I think that we've always given the advice when we teach the course or talk to clinicians, if they don't have fidgety at your first filming, that you should film them again. But now we really have the evidence to support that recommendation, I think, with this paper. So it means that, if we look at all of these babies in this study, the sort of sweet spot, even in the lowest prevalence group, was between 14 and 16 weeks. And that, I think, is a little surprising. I think that's a little later than we thought because like from the original work that said that it could end at 15 weeks. So I think it helps us to decide when is the best time to test them and how to follow these babies to really understand what's the highest chance of catching these fidgety movements among all babies that were tested in our group.
Yeah, for sure. So from here, what would you recommend to clinicians to think about when they are following up these infants that are coming through their clinics, I suppose?
Yeah. So I think that most babies in the group do have fidgety at 12 weeks. So I think that a lot of times what's nice about asking them to come and to schedule a follow-up or to have the parents send a video between 12 and 14 weeks is that we know then if they have it, great. We don't need to be concerned. But if they don't, then we'd like to get another video of them between 14 and 16 weeks. So a little bit beyond that, we know most of the sample, actually, they start to go away as the babies start to do more intentional movements, like reaching and rolling. And so we don't want to wait too long because even though a lot of the babies still have fidgety going on, some of them don't. So we want to be sure sort of to film them probably between 12 and 14 weeks. And if they don't have fidgety, to take another one between 14 and 16 weeks. And that way we can be pretty sure that we're capturing most of the kids.
That's brilliant advice.
And it's not a big time frame. And what you're asking is not a lot either. So to be able to give the family reassurance or more precise direction for something that is a video assessed by trained is quite amazing what the outcome of this. And even if you're asking the families to do that one more follow-up, it's not
too much more, but it's going to be so beneficial. Yeah.
Now, how do these results contribute? I know such a big field of early intervention and in terms of diagnosis and I guess intervention for cerebral palsy. Are there any policy or training implications for follow-up clinics, do you think?
I think that when, and a lot of people are still organizing their follow-up clinics, that we don't want to wait until the first visit is after 16 weeks, right? Or that the first visit is 8 to 9 weeks if we're looking for GMs, that we really want to sort of schedule probably the first visit between 12 and 14 weeks with another possibility in case they miss an appointment. Now, look, I mean, especially if they're bringing their babies into clinic, it's easy to miss an appointment. I mean, kids get sick, life comes up, that we have this tight window in which we know that we should schedule the visits to be most efficient. And I think also the really big thing that we learned after watching thousands of these videos is that parents are great at taking videos of their babies and that they can really deliver us with great. I mean, I worked in the clinic for a long time and we would bring these babies in and they're in a new environment. Maybe they've been in the car for a while or on the bus and they get to us and they're upset and they're hungry and it's not their best time and they're in a new environment. Whereas the families, they know the environment. The families know when is the best time for the baby.
Perfect. Yeah.
So they send us these beautiful videos that, I think are better for the baby to be in the best state, and better for us to see them sort of at the time that the parent usually chooses this the best. So I think that's another thing is, of course, if the parents don't want to come back in for travel, that this can be done via telehealth, because we don't need to have our hands on, we just need to have our eyes on them, and the parents can take a good video.
And I just think of the implications that has on, funding and policy and where to direct resources. You've identified this tight window, so you can see where resources can be put into. I think about low and middle income countries, and you might have finite resources. So where do you put them? And this window is just such an important window as well. And it just has so many implications for how we can use our resources best, doesn't it? Is there anything else to add to that, you think, Colleen? Yeah.
No, I think that's right. I mean, I think time is precious and difficult, especially for the group that were these kids that have been through the NICU. They have a lot of appointments. I mean, so really understanding the best time that we maximize this is, I think, important for clinicians and also for families, so that we're really making sure we're getting the right time to assess these kids.
Yeah, that's right. And direct them to early intervention straight from there. Like, you're not wasting any time. It's perfect. Yeah.
Yeah.
Colleen, it's so amazing. And like I said, the flow-on effects are huge. And I know, being a researcher and being in this field, I'm sure there's more things to come. So this is my next question is, where to from here? Or what are your thoughts beyond this study?
It's probably already working on it.
Yeah. So what we are working on it. We're almost finished with this part 2.
That's so good.
Dina.
Yeah.
So some of the kids in the study are now 4, but but some of them are just still turning 2. So we actually have generously been funded for the original study that was taking place during COVID, and the current study that's finishing up through the Cerebral Palsy Alliance Research Foundation have generously supported both of these projects. So what we know now from this study that we're talking about is the birth characteristics that are most associated with these trajectories. But we don't know is, what do these trajectories mean for their future? Mm-hmm. So, perhaps we're picking up some signal here that's related with later outcomes. So now we're studying these babies at 2.
Wow.
We're looking at cognitive, motor, and language outcomes, as well as behavior and quality of life. And then, of course, presence of cerebral palsy or other childhood disorders that can be diagnosed at 2. Or leaning towards. Yeah. So that's the next question: is the longer term follow up of these babies. What do these trajectories mean in terms of 2-year-old outcomes? So that's part 2.
That is so good. Yeah. And it's not, I can see how it's not going to end there, Colleen. That you can see, the longitudinal aspect of it. This is rich data that we can learn so much from. So before we project too far ahead into that, when do you think we might catch up again to talk about part 2, you think?
Well, we're almost finished collecting the data. So hopefully soon.
Okay.
Yeah, I mean,
that is fabulous.
Yeah, I mean, it is true. And I think that we have these periods of development where we see additional things. So, motor is really within the first 1.5 years, whereas language can be sort of known by the 2-year, 2.5 to 2 to 4-year outcome. And then,
that's right.
Of course, we have these executive functioning issues that come in later around age 5 and 6. So I'm not sure about age 5 and 6 studies, but maybe we can dream up. Yeah, so there's a lot of work to be done. Their development is a long game.
Yeah, it totally is. Yeah. But my gosh, like that data, that longitudinal aspect of it would be huge. So much to learn from, because I think these are the questions we have now that we know so much more about it. You're like, I wonder how this impacts it. So Colleen, we'll be in touch. We're definitely going to talk so much more, which will be great. I'm looking forward to. Now, before we finish up, we want to wrap it all together, of course, in everyone's favourite segment. Let's head now to Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, general movements at all. I don't know where he's going to go with this, Colleen, but before he gets a question in, Can you summarize this work in about 60 seconds or so? And Ed, you're up for a question. Take it away, Colleen.
Okay, Ed. So babies make these tiny multi-directional movements that start to come in around 2 to 4 months of age called fidgety movements. And they're a key sign that the brain is wiring up on schedule. So in our international study, families sent in short phone videos of their babies from 10 to 20 weeks. And after watching thousands of clips, we found 4 main patterns. One is that they're consistently present through the whole window. 2 is that there's some with early to mid with some drop-offs. So they have strong fidgety movements from 10 to 16 weeks, then fade, which we think is an indicator of typical development, but we'll see. Then there's a later onset group where the fidgety movements are less common in this early window, only about 60% at 10 to 12 weeks, and then nearly all by 14 to 20 weeks. And then we have this group of low prevalence fidgety. So none of these babies had fidgety at 10 weeks, with only about 40% showing fidgety by 20 weeks. And these were often in babies who were smaller or medically fragile at birth. So the key takeaway, I think, is that most babies show fidgety by 12 weeks. So if they're not there, the best time to check again is 14 to 16 weeks. And after 16 weeks or 4 months, most babies naturally taper off. Importantly, if they never appear in this window, that's a strong early sign of cerebral palsy, and it means a baby should be referred for extra support right away. And then finally, a simple phone video reviewed by trained eyes can spot who's on track and who may need help. That's it.
That's fabulous.
So
that was
amazing.
so good. So much work in so little time. All right, Ed, over to you.
The conversation's been fascinating. I've loved learning about this today. My question, and obviously, like I'm an IT person, I'm not a healthcare professional, so my questions tend to skew that way.
They do skew that way. Yeah. That's fair.
So at the moment, like I'm working on a machine learning app in-house at Healthy Strides Foundation. But my thought about machine learning is that it can obviously sense or figure out patterns perhaps a little bit earlier than humans can, or if it's under supervised learning, then it can be a very powerful tool. And I'm just wondering whether, and we talked about low and middle income countries, whether using machine learning in like a mobile application might help to democratize this. So obviously we appreciate people with expertise, and it can be very difficult to find these kind of people in lower and middle income countries, and whether an app might be a first gateway to that screening process. I don't know what your thoughts are about that.
Well, I think she's got plenty to say.
That is a great question, Ed. And we are working on that as well for the exact reason you mentioned. So, so machine learning, you're right, it can pick up on patterns that we can't always see either. And so if we can see it, we should be able to train the computer to see it. And I think you're absolutely right, because while I love my job teaching clinicians about how to do this, there's still a lot of work to be done in training a lot of people. And so if there's some sort of technology that could help us with more screening. And actually in Australia, they're working on a universal screening so that every baby could be screened, perhaps eventually in the future, or at least most babies that graduate from a NICU, which could also be applied to lower and middle income countries. So that's a great question, and we're working on it. So we're working on that too.
Nice
so we'll have to come back again when we crack that case. But we actually have a big international group working on that too.
Oh,
yes,
that's great.
Exactly.
That's so good. This is the power of research, though. I love that more questions come up, and it's just so exciting to see people like you so passionate about the area, just driving the field forward, with a whole team as well. It's so fabulous. So great question, Ed.
Thank you.
On the money for that one. Gosh, Colleen, that was just fabulous. I love that conversation with you today. Congratulations on all of this work and what's to come still as well.
Oh, thank you so much. Yeah, it was really nice to be able to talk about it with you.
Oh, I just loved it. Absolutely loved it. And look, to all of our listeners, this is this is an opportunity to also maybe if you've got other questions and you're headed to the conference at AACPDM, go and find the team and find them as they're presenting this work as well. If you're on YouTube, you'll see what Colleen looks like. So go and find her and ask more questions. And this is just such a great opportunity to think about, your training or where to for your career or how to develop your practice even more. So a great opportunity.
Yeah. Thank you so much, Colleen. Yeah. Congratulations again on just your incredible collaboration across the world, and the outcomes that come from this are truly amazing. So excited for where to from here. And next time you can tell us what you think of Vegemite.
Okay, I've got my work cut out for me.
With caution.
Amongst all the other thousands of things you're doing. It can be your breakfast.
Yeah, that's right. That's right. When you come to Australia as well, I'll look after you. So to all of our listeners, remember, head to our website, researchworks.net. We'll pop a link about everything we've been talking about today and the American Academy, of course. And if you want more of an interactive experience to use the tools of the evidence in all the things that you do clinically, head to researchworks.academy. We have so many resources there that you can use and explore. There's machine learning apps for 2D gait analysis, goal attainment scale tools as well, amongst very many more. It's free. We've put this out there for you to use so that, we just all have the tools of the evidence now.
Yeah, some amazing tools
really
on there for clinicians. Incredible.
Yeah. So head over there, researchworks.academy. But to all of our listeners, we'll talk to you all again really soon. Thank you and goodbye. Bye, Colleen. Take care, everyone. Bye.
Bye. Thank you.